To have you here for a live Q&A with Dr. Delaney, where we'll be answering your general fertility questions and covering a range of topics in fertility care. If you have any questions of your own, please feel free to use the Q&A box or the comment section, and Dr. Delaney will answer as many questions as possible. And with that, I'm going to pass it over to Dr. Delaney. Welcome, Dr. Delaney. Thank you so much for being here.
Great. Thanks so much for having me. I'm Dr. Meaghan Delaney. I am one of the REI docs at Boston IVF here in the Springfield office, but I do see patients telehealth throughout Massachusetts, so reach out anytime. I am a Massachusetts native, and I have lived in pretty much every area of the state, so I could, name most of the towns, I guess, around Massachusetts. And I'm super excited to be here on this almost Friday. So happy almost Friday to everyone. Really looking forward to answering everyone's questions. I do have a few questions that we got ahead of time. So I'll kind of start with those. And then, as questions come in, I will certainly address those as well. The first one here is, can a single follicle release more than one egg? And just for context, a follicle is sort of a little cyst that grows in the ovary, and that's where the egg starts to grow, essentially. So typically we see one egg per follicle. I know that, you see in like chicken eggs, you can have two yolks, it doesn't usually happen in humans. We just grow one egg in one follicle. So that's usually when you do fertility treatments, we kind of count the number of follicles or eggs growing in your ovaries, and we can kind of predict how many eggs we're going to get, with a treatment cycle based on the number of follicles that we see. So I wish we had double yolks in humans, but we don't. Next question. Could total abstinence from alcohol and caffeine, this person previously did those in moderation, but not in excess, actually improve my egg quality or odds of successful embryo transfer? And so, there are a lot of lifestyle factors that can influence fertility and sort of outcomes for success. We do know that alcohol can negatively affect fertility. Typically, we kind of say that 2 to 4 drinks in women per week is kind of what is the limit. And in men, it's 5 to 7 per week. And that's sort of like, for the general population. If you're doing an embryo transfer cycle, it might be a good idea to just limit the number of alcoholic drinks you have per week. A lot of times people will have a glass of wine at the start of their cycle, and then, towards the end when they have their embryo transfer, it might be a good idea to kind of like hit up the seltzer and stuff like that. So, that's a general rule of thumb. Typically anything that you feel in your back of your mind, it may, cause a problem in your cycle. Like I say to my patients, just don't do it. Like, don't even risk it. Don't give yourself the stress about doing that. Caffeine is another thing that's super important, I feel like, to function daily. So for caffeine, for women, it's 250 milligrams a day or less. And for men, it's 500, which is so unfair. But I mean, 500 is kind of a lot, right? So 250 milligrams is typically equivalent to 2 cups of coffee. 500 milligrams is like 4 or 5 cups. If you're in the 1 to 2 coffee cup, range per day, I think that's fine. If you had to pick caffeine or alcohol to kind of like limit during a treatment cycle, I would say limit the alcohol. We have more data on that being potentially negative. Caffeine is much less of a factor. Right. Hopefully that answered your question. All right. Next question. This person is hoping to be a single mother by choice. They're looking for statistics regarding how likely pregnancy is per insemination, how much sperm to purchase. The person is 37 years old. They have no medical history and no fertility issues that they know of. So in general, fertility rates and pregnancy rates depend on a person's age. So someone who is 35 or under if you do an insemination, pregnancy rates are somewhere around 20 to 25% per cycle. In the 35 to 38 range, it's around 20%. And then 38 and above, it kind of goes down to about 10 to 15% in general. Those cutoffs are not like an absolute, it's a kind of like general gradual sort of decline in pregnancy rates over time. But it's not super dramatic. So when you turn 38, it's not like, oh my gosh, like everything's so much lower, thankfully. In general, the number of vials to purchase, things to think about are, how many children do you potentially want to complete your family? If you want more than one, sometimes reserving more than probably 2 or 3 vials at a time might be beneficial. Depending on the donor that you pick, sometimes they have an ample supply available, and you can kind of like keep an eye on how many vials are there in the bank, and kind of make sure that you have extras to get in the future. But in general, I would say, around 2 or 3 vials, per pregnancy, I guess, is a good sort of general rule of thumb. A lot of these banks will store the vials there for you. So like long-term storage may be more cost effective to keep them there. And then I know that, a lot of families, they may run out of sperm. They want to find more sperm of that particular donor. And there's, groups online and Facebook groups and things that you can find sort of like families that have the same donor that you could potentially get vials from them. So like there's various ways to go about doing that. But definitely, talk to your fertility team and see what they recommend based on your particular parameters, your desires, and they can give you a better sense as to maybe the number of vials to select.
That's awesome. Thank you so much for that info. That's so good. I have another question here for you. Can regular consumption of sugar have a negative impact on fertility?
Okay, that's a really great question. Sugar, well, it tastes good. Unfortunately, for some people, it can really be detrimental to their fertility. Sugar, we take in sugar, our insulin levels is a hormone that we produce that keeps our sugar level down and allows it to go into our cells, and our body can use that energy as needed. If you are consistently eating a lot of sugar, your insulin levels can be high. Insulin can negatively affect ovarian function, depending on what your physiology is. I mean, everyone responds differently to it, but if your insulin is high on a regular basis, you can have issues with ovulation, with implantation, things like that. So it can affect fertility. I do recommend getting some blood work either with your primary care doctor or your fertility team to see if your insulin levels are high and if it's causing issues for you.
I think that brings us into our next question, which is about PCOS.
Yes.
Which I know is a big topic in the fertility world. What are the challenges for women who have PCOS and they're trying to conceive? And does Boston IVF support women who have PCOS?
Yes. Another great question. So, we see a lot of patients with PCOS, and it can be incredibly frustrating because I feel like a lot of patients are told you can't ever get pregnant with PCOS, and that's a complete not fact. So please don't listen to those people. We definitely help a lot of patients with PCOS. And a lot of times it's really just getting someone to ovulate. That's the biggest thing. I mean, we need to share our eggs to get pregnant. So we can definitely help patients do that. And a lot of times, there are other health and medical things that can go along with PCOS that can kind of like be an issue for your entire life. So I think we help with the fertility pregnancy thing, but we can also help you just like have a general healthy, life so you can live a long time with your family. So.
Great. Our next question, would you be comfortable doing an FET on a patient with Asherman syndrome if their lining is thicker than 6 mm and has great layers? Have you seen
Yes.
any success there?
Yes. And I think unfortunately a lot of patients have Asherman's, and it's a really hard thing to deal with. Um, I mean, I think the amount of scar tissue that you may have could play a role. Certainly having triple layer, nice, layers of the endometrium is a good sign that it's functioning, the way it needs to. Um, the millimeter cutoff for thickness is a little arbitrary. I mean, we traditionally have this like 7 millimeter, size that you need, or we don't transfer. That's not always true. We can definitely transfer with thinner lining. And it really depends on the person. I mean, data now shows that that number is not, hard and fast. We can definitely transfer under 7 millimeters, 6 millimeters. I mean, the difference between 6 and 7 is pretty minimal as long as you have a triple layer. So I think that's definitely an option going forward. Yeah.
Thank you. Um, how long is too long to be on birth control before the start of IVF stimulation? When is there a risk of suppression?
Yeah. So birth control is actually a really helpful tool to kind of like time an IVF cycle, certainly. It can be detrimental in some patients. Typically, it depends on ovarian reserve. So if a patient has low ovarian reserve, being on a birth control pill for longer than I would say 3 to 4 weeks, it's probably not going to be the best thing for them in terms of starting their IVF cycle. It may not affect their overall IVF outcome, but it may take longer to stimulate their ovaries. You need maybe higher doses of medication. So I would say in those patients, lower egg reserve might not want to be on it for longer periods of time. Now, on the flip side, if someone has a normal ovarian reserve, or if they even have a high ovarian reserve, being on the birth control pill can actually help someone kind of like sync their eggs to be at the same stage of development so they all grow at the same time. And in general, like, being on the birth control pill for 3 to 6 weeks for those kind of patients is probably not detrimental. It may actually be beneficial.
Um, what is the full timeline for egg retrievals and frozen embryo transfers? Can you please explain for each? I think this is a great question.
Yeah,
Yeah.
I think a lot of people have this question, definitely. So for an egg retrieval, typically it takes about 10 to 11 days to grow your eggs. So you're taking medication during that time to grow the eggs. You're having some monitoring, ultrasounds, and blood work to see how you're responding. And then once the eggs are ready, we do what's called a trigger shot. That's going to get your eggs ready for retrieval. And then 2 days later is the retrieval. So 10 to 11 days of egg growth, 2 days later is the retrieval. And then if you're doing a freeze-all cycle, so if you're getting your eggs out, fertilizing them, and then growing in the incubator for 5 to 7 days and freezing them, that would be a complete cycle. Some people will do it what's called a fresh transfer. So they will grow their eggs, fertilize them, and then 5 days later they have an embryo transfer, and then they freeze embryos that are left extra, essentially, for that cycle. If you're freezing your embryos, after you do your egg retrieval, you get a period in about 7 to 10 days. And with that period, sometimes we can start a frozen embryo transfer, but oftentimes, I mean, especially in Massachusetts, insurance kind of like dictates the timeline a little bit. So insurances require an authorization for every treatment cycle that you're doing. So a fresh IVF cycle and then a frozen requires 2 separate authorizations. So there may be a month in between before a frozen transfer.
So I think that brings us into our next question, which is another good one. Does Boston IVF allow embryo banking if we're not ready to do a fresh transfer?
Yes, we definitely do embryo banking. And again, it's the insurance piece a little bit in this regard. Some insurances will allow patients to embryo bank. Some of them don't. Depending on, I guess, your perspective or timeline, if you use your embryos within 12 months of creation, that's like a different category than if you create embryos and then you use them more than a year later. So insurances have all these little fine print things that we need to like work through. We have financial coordinators that know all these details and they can go through everything with you guys about what they cover in terms of embryo banking. But we have plenty of patients that do that. We store the embryos on site. They're incredibly safe in these robotic things that keep them safe. There's actually no time limit on the number of months or years that we keep them. As long as you use them by age 50, they're going to be good until then. Definitely. Hopefully that answered the question. That was a little, I don't know, insurance does dictate it. So you may want to definitely, you can reach out to your insurance company and get, your question answered there. If you're a patient here at Boston IVF, we definitely have financial coordinators that can go through all those details with you.
Great. And here's another question about IVF. What are the stages of the IVF process? Do you have to start with IUI? Does it depend on the patient? What's your outlook on that?
Yeah, yeah. Yeah, I mean, in the fertility sort of treatment options, we really do have two basic treatments. We have IUIs and IVF. For IUIs, if you have unexplained infertility and we just like do all the testing and everything's fine, an IUI is a good first step to go down. The sperm's okay, the tubes are open, the uterus looks okay. That's a good option. The pregnancy rates depend on age, kind of like I went through before. So, a younger person may have better chances versus an older person. The other option is IVF. And so that is a good option as well, even if you have unexplained infertility. Like that's a treatment for unexplained infertility. Pregnancy rates can be 50% or higher per embryo transfer. And so that can be an option. Again, I feel like, in Massachusetts, we have the benefit of having a lot of people with insurance coverage, but they do actually somewhat dictate what treatment you may be able to do first. Some insurances say, hey, you have to do 3 IUIs before you do IVF. Some insurances say you can do whatever you want. You can do IUIs, you can do IVF, whichever you choose. So that sometimes can tell you your option. If you do your testing and the sperm counts are low, typically if they're under 5 million motile sperm in a sample, IUIs typically aren't as successful, and you may actually be better off doing IVF. If one or more of your tubes are blocked, if you've had ectopic pregnancies, things like that, maybe IVF might be the better first step for you at that point.
Here's another question for you. I know people often take a month off between other treatments like IUI and starting IVF due to insurance, like you said, and preparing for IVF. What does this month typically look like? Do you have to be on medications? Are there any limitations? What does that in between time look like? And maybe if you could provide some tips to get through it, to wait for it while you're waiting. I know it can be stressful sometimes. So yeah, that'd be great.
Yeah. No, it can be a really hard time because waiting, you feel like you can't do anything. You're just in limbo. So I definitely feel that for people. So, you can certainly, I would say some people use that time to just decompress. It is so hard to go through these treatment cycles. Definitely IUI, IVF, either one can be incredibly challenging. So I say, rest, do something fun, go on vacation, do something to just keep your mind off it and get some rest and relaxation. You don't necessarily have to be on medication. I also say try on your own if you want. If it, I've had plenty of people get pregnant in the cycle in between their cycles. So, sometimes just kind of taking your mind off it, people can get pregnant on their own. You can, work on, there's any lifestyle things that you want to work on, that could be a time to work on that. Some people will go on medications through their primary care doctor to lose a little bit of weight. Sometimes that helps, and that's something you could do in between. Um, I mean, I think it's just, it's hard to keep your mind off of things, but I would say get rest, do things that you like, have fun with your friends, go on vacation, have that extra glass of wine that might be helpful, so I think, all those things can be helpful. So,
Great, thank you. Sorry, I threw you for a loop with that one.
yeah.
Uh, um, 3 failed transfers with PGT euploid embryos. Unsure of what to do and ask next as a follow-up. Could you just throw out some things that are not commonly checked during a recurrent loss panel that I've already had? Already checked APS, endobiopsy, karyotype, etc.
Yeah. Okay. And this is a tough one, and I'm so sorry that you've had to go through this because this is, you have these normal embryos, you're hopeful, and then all of a sudden, they don't work, and that's so hard. So, the data that we have says that most couple or patients are pregnant by the third transfer. So at that point, we can start to do a little more investigation on things. And so things that I kind of recommend for people, it sounds like you've already had the endometrial biopsy, and that's typically looking for inflammation. They usually do stains for CD138, and that is something that is associated with inflammation. If you have that, we treat it with antibiotics and it usually goes away. Sometimes doing something called a hysteroscopy can be helpful. And so, a lot of times getting ready for a frozen transfer, you have something called a saline ultrasound. You put a little catheter in the uterus, we do an ultrasound, and we can see like the lining of the uterus on ultrasound. Sometimes that misses things. I mean, no test is perfect. And so sometimes actually looking with a camera in the uterus called the hysteroscopy can be helpful. We can sometimes find things at that point. If there's a little polyp there, if there's some scar tissue, we can find that and remove it at that same time. Sometimes we can get a bigger sample of the lining of the uterus. So when you do the endometrial biopsy, it's a little kind of like scraping with a little tiny catheter. With a hysteroscopy, you can get a bigger sample of the lining to make sure that we didn't miss inflammation in other spots of the uterus. So that's an option. I would make sure that your fallopian tubes have been reassessed in the last year or so. There's a couple ways to assess the fallopian tubes. One of them is called an HSG, and that's where they take an X-ray. So we put dye in the uterus, it goes through the tubes, and you take an X-ray. The other way is the saline ultrasound, where we blow little bubbles in the fallopian tubes, and you can check them that way on ultrasound. That's called a hycosi. I would say if you haven't had the HSG, which is the X-ray one, I would recommend maybe considering doing that. If you have a blocked fallopian tube, some of that fluid can sometimes go back up into the uterus, and that's toxic to embryos, and they don't typically implant or do well in that environment. So double check the tubes. There's a couple of tests that have mixed sort of data on them. One of them is called a receptiva assay. And that's an endometrial biopsy that's looking to see if someone has endometriosis. Endometriosis is where the lining of the uterus grows outside. So it could be on your ovary, it could be on your fallopian tube, in your pelvis somewhere. Your body is like, what is this? This is not supposed to be here. It fights it. So you get inflammation, and inflammation is not good for embryos. And so if you have endometriosis, it's hard to diagnose usually. That's why people go years and years and years without ever getting that diagnosis. So the only way to really officially diagnose it is to do a laparoscopy. That's surgery. So we don't recommend people just have surgery to see if they have endometriosis. That's we know that that's not really helpful. But this biopsy can highly suggest that you may have it. And if you do, you can treat with certain medications to suppress the endometriosis for a couple months before a transfer, and that can actually improve implantation rates. So that's an option to do that test. There's another test called Alice and Emma. That test is looking at the sort of a bacterial overgrowth in the uterine cavity. And so some bacteria is good and it's supposed to be there, some is bad and it's not supposed to be there. So that test can potentially detect good and bad bacteria. You need good bacteria, but you don't need bad bacteria. So that test can be helpful. There's another test called endometrial receptivity assay. And that's looking at the window of implantation for when we put the embryo in. So there's a very like specific time frame where all the little receptors and things are doing what they're supposed to do. And it's a very short window for the embryo to actually attach and start growing. And so that assay can actually detect if you're putting the embryo in at the right time. So you do basically a mock cycle. You do a embryo transfer cycle, and the time you would transfer the embryo, you do an endometrial biopsy, and you can determine if that's the window of implantation. So the endometrial is called an ERA. That, the allocinema, the receptiva, they're all good, tests in general, but there is some controversy with them, definitely. Some of the data is not great. So, it could go either way. I mean, certainly something to talk to your team about if that's a good option for you. But those are definitely things that could be, looked into certainly more. Hopefully that was helpful. Okay.
Okay. So moving on, I guess you mentioned a little bit about mock transfers.
Mhm.
When are they recommended? I think, and does Boston IVF do them?
Yep. So at least at Boston IVF, we typically do like a mock transfer at the time of an embryo transfer. But there's other times before that we kind of assess, how easy it is to pass a catheter. So, women have to have, their uterus evaluated prior to any fertility treatments. So the saline ultrasound basically passes the catheter through the uterus. And definitely if there's issues with passing the catheter at that time, we would probably do a mock transfer before an actual embryo transfer. So, and that's essentially just like going into the office, using an ultrasound, making sure that we can pass the actual embryo catheter through the cervix without any issues. We want a nice, smooth, easy pathway for the embryo. When we do the actual embryo transfer, when the embryo is getting ready to be put in, we do a mock transfer. So we put the catheter in, we place it in the uterus, make sure it's nice and smooth. And then, so we kind of like do that ahead of time. If there's any issues, we don't load the catheter until that catheter is in the uterus and ready to go. So we kind of like make sure that there's a smooth passage for the embryo at that time. But we do, there's times ahead before that time, to find out if there's any issues, and, certainly address them at that time. So I've had patients that, we can't get the saline catheter in. And so, we do the mock transfer in the office, still can't do it. Sometimes you need to have some anesthesia and dilate the cervix, things like that. There's definitely things we can do to make a transfer easier and more successful.
That's helpful. Somebody would like to know, if they have high estradiol, does that mean they have lower progesterone?
Um,
Or
kind of a
is
hard
it,
question.
yeah.
Yeah, but very insightful. So,
Yeah.
the estrogen does fluctuate throughout your cycle, and I guess it depends on if the person is ovulating. But like, let's say they're ovulating, they're having regular cycles and ovulating. At the beginning of a menstrual cycle, estrogen is pretty low. As an egg starts to grow, that's when the estrogen starts to rise. And then once it ovulates, it drops a little bit. And then if you're not pregnant, your estrogen will drop down and you'll get a period. Progesterone, is also a factor in your menstrual cycle. And so once the egg is released, then progesterone starts to get made. So the egg comes out of what's called corpus luteum in your ovary, and it gets picked up by the fallopian tube. That corpus luteum, that kind of like follicle that's left in the ovary, that starts making progesterone. And so progesterone stays high until the body's like, okay, I'm not pregnant, and then the progesterone drops. So it depends on the part of your cycle. sometimes people just have kind of like not they don't ovulate and they just have sort of like steady estrogen levels at all times. Typically the estrogen is not super high if you're not making an egg. It may be like 50, 60. That's kind of just like a stable baseline amount of estrogen. Progesterone is only made when you release an egg. So if you don't release an egg and you don't have a corpus luteum, you're not going to have progesterone around. Um, they kind of they don't really work. They don't really influence each other per se. It really is dependent on an egg being released or not. If that makes sense. Hopefully that made sense for them. But
Great. So if you're 37 years old, do you recommend getting the retrieval first or transferring existing embryos, which have been banked for more than 3 years?
okay. So assuming that, the embryos were around age 33, 34, if they have not been genetically tested, at that age, they have about a 55% implantation rate and about a 10% miscarriage rate. So, I mean, one of the biggest factors on whether to do another retrieval versus transfer is kind of like in your mind, what would be how many children would complete your family? Like if you just want one more child, maybe transferring actually would be fine. Did they say how many embryos they had?
No,
No. And if
no.
you have like 2 or 3 embryos in storage, that's a good odds for having a live birth from that cohort. If you want more than one child, it may be a better option to do a retrieval at that time, especially if you have multiple embryos and you're not sure how many months it will take to kind of transfer those. Um, if you're 37, you do a transfer and you get pregnant, you won't be able to do another egg retrieval until you're, 38, 39 potentially. And so that can be, a factor in success for a second pregnancy. Um, so just decide your ideal family size and then maybe extrapolate from there.
Yeah. Um, do you know if any vitamins deficiencies could cause fertility issues like vitamin D or iron? Any of that
Yeah.
ever come across your desk?
Yeah. Yeah. I do routinely check all my patients for vitamin D deficiency. There's some suggestion that affects fertility, maybe implantation. So I do check it routinely for people. Pretty much everyone in Massachusetts is deficient. I mean, you can just assume that you are. I usually have people on about 2,000 units of vitamin D3 every day. And that usually overcomes the deficiency. Some people need to be on higher doses. The one caveat I would say is I would, before people run out to get vitamin D to take it, I would have your practitioner check it first. You can actually overdose on vitamin D. It's a fat soluble vitamin. And so if you take too much, you can actually get sick from that. So make sure that you're on the right dosing and have your practitioner check it. So vitamin D, definitely, I check for everyone. Iron is important for pregnancy in general. So, I mean, it doesn't necessarily affect fertility per se, but it's super important to have, optimize your iron levels in any anemia that you have, because in pregnancy it can really be an issue because that fetus will feed off anything in your body and you can get pretty depleted and get sick. So, make sure that's optimized before pregnancy. In terms of other vitamins, I mean, vitamin D is the big one. Definitely. If you're a vegetarian or if you have certain like dietary restrictions, sometimes checking your B12 could be beneficial. And certainly, your primary care doctor can definitely do that. And I would say they mostly routinely do that for vegetarians, but maybe ask them if they would check that for you.
We have another good question here.
All right.
Do you recommend genetic testing on your first IVF cycle?
So the genetic testing is the pre-genetic implantation testing, and that's PGTA for aneuploid. Aneuploid is abnormal embryos, euploid is normal embryos. And I really kind of recommend, I mean, it's certainly an option for anyone, definitely. I do recommend it a little bit stronger for women over 35. Typically, as we age, our eggs age. And so there's just a more chance for the aneuploid, the abnormal embryos, as we get older. So it's certainly something to consider if you're over 35. If you've had multiple miscarriages, I mean, sometimes doing the genetic testing can be helpful to potentially prevent another miscarriage because it's so hard to go through those. So that could be an option. But even if you're 27 and you have lots of embryos, like sometimes genetic testing can be helpful to, know which embryo to put in next. So, I mean, that it can be helpful for a young woman or an older woman. But it's not something you have to do. Even someone who's 41, you absolutely do not have to do genetic testing. But it can certainly speed the time to pregnancy and prevent miscarriages.
How often is infertility a result of sperm? Trying for baby number 2 for 10 months. My husband had experienced but recovered from a kidney liver injury last year.
Mhm, mhm. We find male factor infertility about 40 to 45% of the time. I basically tell my patients 50-50. I mean, so I mean, having a liver and kidney injury can be pretty stressful on the body. So I'm sure, there was a period of time that his body was under some significant stress, and that can definitely impact sperm. Depending on how fast his recovery was, the sperm can recover. Sperm's life cycle is about 3 months. So, he could, if he's back to his normal state of health, his sperm can recover. But approaching a year of trying, you may want to reach out and just have the basic testing done. It's easy enough to do a semen analysis, certainly. A man can collect at home and drop it off at the office, or collect in the office. So it's generally minimally invasive procedure for them, although they do complain somewhat about it. It's okay. So, but you can just encourage him. But and it's not their fault. Like, if he has a sperm factor, we can do something about it and really help him. So encourage him to maybe reach out and have that tested.
Great. What advice can you give a person who will be doing their first FET? Um, they're nervous about the success rate for the first time. They've been on the blogs and seen other women go through it 3 or 4 times. Any advice you can give?
Yeah, yeah. Well, just know that, like, I mean, the hardest part you've gone through, like the retrieval and all that stuff. So like the actual transfer, it should be a fun time, although I know it's stressful. So have a moderately full bladder. Bring a supportive person with you if you would like. You get to watch on the screen and see the catheter being placed and the little embryo sparkle when they put it in. And just know that, like, there's nothing that you can do afterwards to cause it not to work. So like you can go out to lunch, you can go to the grocery store, you can like live your life, and it's not going to be detrimental to the embryo. Um, so keep that in mind, because I know a lot of people want to blame themselves if it doesn't work. But just know that, like, it is like basically, often 50-50, and it might just be that just wasn't the embryo. And I know that, I mean, we all want it to be the embryo, but don't beat yourself up. Like, know that if you stick with it, you're going to be successful. It may take some time, but at least at Boston IVF, our teams are really supportive, and we try to, coach people through it. But just know that, you're going to do everything right. You're not going to mess anything up, and always reach out with questions if you're worried about something.
I think we have time for two more questions.
Okay.
This one, do you have a license to see Rhode Island patients?
I do not have a license for Rhode Island, unfortunately. I'm so sorry. But we have some awesome providers in Rhode Island that can definitely take really good care of you, definitely. So,
Yeah, we have an office right in Providence. Dr. Katie Baker and Dr. Kerry Luzo are fantastic doctors, just like Dr. Delaney. So they would be happy to see you. Let's move on. How long do you take meds for an FET? And are you able to travel in that time? Are there any restrictions?
yep, yep. Depending on the protocol for the frozen transfer that you've done, kind of dictates maybe the length of time. So if you do something called a program cycle where you're taking estrogen and progesterone, so they're giving you all the hormones you need to support a pregnancy. I usually have my patients take it for 12 weeks. So yeah, at the end of the first trimester. And keep in mind that when you do the embryo transfer, you're already about 5 weeks pregnant. So it really is like 7 weeks of medications essentially after the embryo transfer. If you do a more, quote, natural cycle where you're ovulating and making your own hormones, we typically stop medications anywhere from 8 to 10 weeks pregnancy. So a little bit less time because you have your own, hormones already in the system. So
Great. Let's do one more question
sure,
because
yeah,
we have the time and you're
yeah,
here and we might as
absolutely.
well. So what are the chances of IVF success at 37 to 38 years with somebody who has diabetes?
Yep, yep. I mean, I think with diabetes, the most important thing is to have really good sugar control. We typically want your hemoglobin A1C to be 7% or less. I mean, ideally in the 6% range. And like I think earlier in the podcast we talked about like insulin. And insulin, if you have high blood sugar levels or high insulin, that can negatively affect the ovarian function. And so that's why it's super important to have tight sugar control so that your ovaries are functioning the best they can. So at 37, 38, if your sugars are optimized, your hemoglobin A1C is where it needs to be. I mean, you're looking at like a 40%, 45% chance for pregnancy per embryo transfer if you don't test your embryos. If you test your embryos, it's 65%.
Great. Well, thank you so much. This has been fantastic. We got so many great questions.
Yeah.
Thank you, everyone, for joining us. We have many more of these to come. In fact, your colleague, Dr. Dawkins, is doing one
Hey.
in a few weeks.
Awesome.
So we'll send you an email with more live Q&As. And thank you, Dr. Delaney.